Hello, everyone, and thank you for having me for this 17th session of the World Congress. My name is Amin. I work for MSF as a referent for anesthetics and critical care, and as such, I'm involved as a contributing specialist in the telemedicine platform that we use in MSF. And so I've been kindly asked to give a brief overview around the intersection between telemedicine and emergency medicine within Médecins and Frontières. So this is just to say that I have no conflict of interest nor financial disclosure with regards to the material being presented here today. So first, I'd like to give a brief overview about what MSF is and what it does. So MSF is one of the biggest humanitarian organizations in the world. We have activities in about 70 countries around the world. It provides healthcare to people affected by violence, disasters, but also people who lack access to basic healthcare. Just key figures to give a little bit of perspective on the volume of activities. These numbers are from last year. In 2020, there were more than 11 million consultations being held in MSF facilities. Most of them are being done in outpatient departments and about 10 to 15% in emergency departments. Now, with that being said, most of the activity in MSF occurs at district or rural level. And so these are places with limited access, both in terms of geographical access, but also access to technology and access to specialists. So it comes as no surprise that MSF has tried to look into technological solutions to try to bridge these gaps. And so around 2010, we started piloting with telemedicine through different platforms. And this has evolved and become a full program being managed by a whole team within MSF Canada since 2016. And since then, we have now available a telemedicine platform in different forms, in different platforms. Most of the activity goes through the asynchronous service, which is what we call the store and forward. So this constitutes the bulk of the activity, and it's essentially a web-based, secured platform through which the referrer can submit a case, and we have a number of specialists who can respond to these cases. We have been piloting through the recent years more synchronous services. So this includes real-time and secure messaging. Real-time being essentially video conferencing, which allows case discussion, but also in certain situations, direct patient consultation, teleconsultations, and secure messaging being basically using a secure app to exchange text messages or media with a specialist. Now, I'm going to talk more about the store and forward, since this constitutes the bulk of the activity. Last year, this was used in about 100 projects throughout MSF, and I think about 30 countries are currently using it. We have on the platform about 400 specialists ranging from dermatology, pathology to cardiology. So this allows us to have access to a number of specialties that we don't necessarily have available within the project, but also at headquarters, we don't necessarily have on the payroll a dermatologist full-time. And a number of these specialists are MSF staff or former MSF staff, but the majority are external specialists that go through a validation process and a number of briefings to be validated to be on the platform. Now, this platform treats about 3,000 cases a year. I think 15 cases in total since we started using it. The median response time is about 6 hours, and this is for all cases in general. Now, how the platform works, as I mentioned, it's a web-based application. There's a login portal. The referrer can submit a case. So it is essentially filling a form, but they also have the ability to upload images, videos, and documents, be it reports or anything else. The case is then available to the telemedicine coordinator. So we have coordinators available 24/7 throughout the year. Coordinators try to process the case and find the appropriate specialist as soon as possible. Then the specialist receives a notification either by email or through text messaging. And so 6 hours is not necessarily adapted to emergency cases as a response time. In such cases, the referrer has the option to highlight that the case is urgent by ticking a box simply. And in these cases, the coordinator can assess availability of specialists generally outside of the platform through a group messaging to contact. We got a pool of volunteer acute care specialists. So this includes anesthesiologists, critical care specialists, emergency medicine specialists, and surgeons, and so on. We have the chance to have people who are living in different continents and so through different time zones. This allows us a lot of flexibility and reactivity, and to bring the response time down to less than 1 hour. Now, this is the breakdown of the consultations by the specialty. This does not necessarily reflect the original condition of the patient, but more the consultation being asked for. And so a substantial number is about reading of imaging, be it CT scans or ultrasound clips. A substantial number is within the pediatric population, which is about a quarter of all the consultations, and the rest is more or less distributed equally throughout the other specialties. Now, real-time video conferencing, this has been piloted in about 10 projects and has supported about 120 cases. It has primarily been used to have clinical case discussions. So basically, on a scheduled time, there would be a group of specialists attending the discussion with the medical team, and they would review a number of cases that present a given clinical challenge. And so this allows as well to give clinical supervision for specific activities, although this hasn't been used that much. And so the other solution we have been trying out is secure messaging, which is essentially using a dedicated mobile app, secure mobile app, which is Silo in this case. This has been trialed in a number of projects you can see here on the map. And the response has been quite positive so far. There's a number of limitations here. These are mostly in terms of capacity of the system to actually process the number of cases should this solution be implemented more widely. So just a brief word around the limitations and way forward or vision that we see for telemedicine within MSF. Technological limitations are obviously the ones that would come to mind first. Although internet access nowadays is nowhere near what it was 10 years ago, it is still a challenge to have the broadband available within the facilities and the computers available to staff close to the point of care. And so we work with a team of implementers to try to help the projects set up all the equipment necessary to make this function. The second limitation is about service uptake. We do have quite a bit of turnover within the organization, and it's about spreading the word and making sure that the service is not perceived as an added burden, but rather as a benefit for the staff and for the patients. The third limitation is mostly on our side to try to make sure that the advice that is being provided, or that the specialists we have on the platform have enough information and briefing around what level of care is available, what diagnostic options are available, in order to really tailor the advice to a given project and not just give some generic advice. And so with that, I want to say thank you. I leave here a link if anyone is interested to maybe join the platform as a specialist. You can submit an application. And if you have any questions, I'm happy to answer them. Thank you.